Did you
Yeah,
have anything in particular?
if you don't mind, could I maybe take 5 minutes of your time just because Holly said she needs to participate in both just because she is her organization's executive director and also the person who does place the sealant and also the one who does that stuff. So if I can do maybe a 5 minute like speed run, see if there's questions and then kind of answer those as well.
Yeah,
Um,
Or
I have an
actually
idea.
another idea too. Yes, Nancy.
Yeah, I mean, if you want to, maybe you could offer yours at another time. It's an option.
I think
Kind
I
of.
lost everybody.
Yeah. I
Oh,
was
there you
just
are.
thinking, yeah, maybe you could offer yours at another time, and
Yeah,
that way nobody has to decide.
think it's a good idea to maybe do it on another day so that it can be maybe more comprehensive instead of
I think that would be great. It's up to you guys, but I think that'd be a great idea. Then nobody has to choose, and they get a thorough presentation from you.
Hi, sorry about that. It just kicked me out. I think my Wi-Fi is being weird. But what if I will send an invite for a date from 2 weeks from now, and then that way everyone can have the same type of information and we can kind of just do a Q and A. And what I can also do with that is use that as an opportunity to do an RFP like community hearing so that if people have questions specifically on how to apply for the Seal Minnesota grant, they can also get kind of more of those nitty-gritty details then and then kind of do things like that. Is that going to be okay? Perfect. Well, Prashida, you are great, and I will let you take it from here. And I am really excited to see everyone tomorrow.
yes. And Declan, I know you have to go to the library to get things going. So why don't you go? And Nancy,
Yep.
would you please confirm you're
Bye.
able to see my slides? You can see me and I can start. I just need to get your okay.
Me? Yeah, I'm okay
I
with
just,
you starting.
yes. And then you are able to see the screen, right?
Yes,
Yeah,
we
we
can.
can see the screen just fine.
Yeah.
Okay.
Yep,
Okay,
we can see your
perfect.
screen.
Okay. Good afternoon, everyone. Welcome to the second half of our SEAL Minnesota Forum 2023. And this is going to be a standardization training. I believe many of you know me already. My name is Prasida Khanal. I'm the State Oral Director. For those of you who may not know about my background, I was trained as a dentist in Nepal, moved here, did my Master's of Public Health, and also completed a dental public health residency from New York, halfway through my board certification already. And today I'm joined by Dr. Kathy Phipps, who would be helping me answer questions that might come up. Dr. Phipps, do you want to say hello to the audience and then introduce yourself? And then maybe we can move forward after that.
Sure. So this is Kathy here. I live in California. I think I have met some of you. I am the Data and Surveillance Coordinator for the Association of State and Territorial Dental Directors. My background is that I went to hygiene school back in the 1970s and then also have a master's in public health and a doctorate in public health in epidemiology.
Thank you, Dr. Phipps, for joining us today. And thank you, Claire. I see you here. So, if something comes up and you've been the expert for Minnesota for so long, so help me answer those questions. So we will move forward. So before I get into the presentation, I wanted to take a moment to acknowledge Centers for Disease Control and Prevention for awarding us the DP 18-1810 Actions to Improve Oral Health Cooperative Agreement. And I also would like to thank the Association of State and Territorial Dental Directors for providing a lot of information regarding the standardization training for school-based sealant programs. So Endekla talked about SEAL Minnesota in the morning. Again, just to reinforce our commitment, SEAL Minnesota is a statewide coordinated approach to school-based sealant program. We are very committed to the goal of access to care for all children, We are also dedicated to the promotion of dental sealants for all children in need. And we are so proud of our grantees as well as our partners who are part of this public health initiative. And this presentation, the Seal Minnesota in itself, is a strategy that has been listed in the Minnesota State Oral Health Plan 2020 and 2020 to 2030. So as the recipient of the CDC Cooperative Agreement and also as the steward of public funding, MDH Oral Health Program is responsible for providing technical assistance to local school-based sealant programs so that we help them be more successful. So that's what we are doing today, trying to provide all the evidence-based resources and also talk to you about Minnesota Oral Health Program specific best practices that our grant managers and providers may benefit as they implement the school-based sealant program. So the way I've structured today's presentation is rather than trying to keep it only clinical, I'm trying to start from the bigger picture of why we are even doing this, the school sealant program work, and then provide you with some data that shows inequities in childhood dental caries, then talk about dental sealants. I will also review evidence-based guidelines for school-based sealant programs and discuss the implementation of the school-based sealant programs also. Then we will get into a little bit of more clinical aspect of the training where we would learn about standardizing the process of selecting teeth for sealant placement. There is, I would believe, a couple of slides that talks about infection control protocol. And towards the end, I will share resources for school-based sealant program implementation. So for those of you who may not be familiar with the term standardization and calibration, a standardization training basically includes a didactic presentation to assist with tooth selection criteria using clinical photographs for dental providers who place the sealants. But when you talk about the term calibration, it just means that in addition to doing these didactic presentation, we also look into the mouth of children to determine the status of tooth surface, whether the tooth surface is sound, cavitated, or non-cavitated. And then we try to build consensus on whether it is appropriate to place sealants or not. The goal of dental provider calibration is to obtain excellent inter-examiner reliability. And I know when Claire Larkin was our planner principal, she was able to organize a big in-person calibration training at Normandale Community College. We've not been able to do the calibration training for a very long time, but there has been conversation going on about the need for calibration training. So for today's presentation, we are focused more on standardization of the school-based sealant programs. So I will start with the background and try to give you the bigger picture of social inequalities in childhood dental caries. We all know that dentistry has been separated from medicine, and it's been so long that we've experienced this divide. So whether you have insurance is one thing, whether you have dental insurance is another. Your doctor doesn't ask you if you're flossing, and your dentist doesn't ask you if you're exercising. And this is a very bizarre condition that Mary Otto has beautifully described in her book, The Teeth. And I'm sure many of you must have read this book. And in this book, she also talks about how even though medical and dental specialties have been so divided, which led to further, division of the insurance system, the education system, and it led to a lot of access issue. Mary Otto talks about how the body didn't sign up for this arrangement, and teeth, they don't know that they're supposed to keep their problems confined to their mouths, and that leads to real consequences. And one of the real consequences of this divide is Demonte Driver, a young boy in Maryland who lost his life because of the adverse consequences of a tooth decay that could have been prevented, that could have been halted, or that could have been just managed with a root canal or an extraction. He lost his life because of the brain, abscess, which was the consequences of an untreated tooth decay. And these things are so real. So the demonted driver story also emphasizes the oral systemic linkages. Sometimes you look at tooth pain and dental decay as something that's confined to the mouth, but as we have seen in demonted driver's case, the infection from tooth can really spread all over the body, and oral and chronic diseases are also linked with each other. So the association between dental and medical diseases is really attributed to the presence of the plaque that leads to inflammation, which causes different kinds of chronic diseases or increases the risk for getting those diseases. So even though there is so much to celebrate about ongoing improvements in oral health, many children still suffer from early dental disease and lack of access to the care they need. And this morning, we did talk about a lot of barriers that we are seeing that our children are facing. It could be barriers simply seeking care, reaching care, or even receiving care. And we also discussed this morning how over half of the Minnesota counties have dental workforce shortages. So we already know that there aren't enough providers to treat children with dental disease. On the other hand, more than 50% of children eligible for child and teen checkups in Minnesota had seen a dentist in 2018, and only 38% of them actually received the preventive services, which includes sealant, fluoride varnish, and other treatment modalities. We know that many children in Minnesota do have dental insurance. It looks like only 13.2% of children under 18 years do not have dental insurance. But as folks who are working, boots on the ground, you know how dental insurance does not guarantee the utilization of the care. There are many social determinants of oral health that impedes the ability of our families and children to actually get the care they need. So when we did our last basic screening survey, which is the open mouth assessment of third graders in Minnesota, we found that half of Minnesota's third graders have tooth decay. That's like 50% of third graders had tooth decay, and 17% of them have untreated tooth decay. So think about the pain. Think about how they may not be focused on education just because they have untreated tooth decay and they're living with the consequences of untreated dental infection. So because of the poor health, their school readiness is impacted, which also impacts their overall health and well-being, their learning and their attendance. So we know that healthy children are ready to learn, but if our children continue to struggle with cavities and the consequences of cavity, it impacts their school readiness and overall quality of life. So there are evidence-based public health approaches that have been recommended by the CDC, Centers for Disease Control and Prevention, to prevent tooth decay or to mitigate the impact of tooth decay. And we know that those two evidence-based strategies are dental sealant, or community water fluoridation. And today we are going to take a deeper dive into dental sealants. So before I jump into dental sealant, I wanted to take a moment to think about, what goes on inside our mouth. Literally, there is a tug of war. There's a tug of war between bacteria and sugar on one side and saliva and fluoride on the other side. So throughout the day, there is a tug of war going inside our mouth, and therefore, the imbalance between the risk factors and the protective factors is what determines the pathway for the caries. So either the caries is going to halt, it's going to revert, or it's going to progress. Depends on the protective factors and the risk factors, and actually the balance between that. So the sealant is definitely one of the protective factors which could prevent the tooth decay, and tooth decay is an infectious disease that could spread all across the body. So dental sealants is really a very simple, clear, opaque material. It protects against 80% of cavities for a couple of years, and it continues to protect against 50% of cavities for up to 4 years. And children aged 6 to 11 years without sealants have 3 times more first molar cavities. So if you look at the population oral health for dental sealant and look at these 3 levels of prevention, sealant actually is amazing because it is both the primary prevention strategy as well as secondary strategy. So when we look at sealant as a primary prevention strategy, we have to think about our molars. So molars have those grooves or like grooves and pits that collect the food and the debris, and then it leads to the formation of the biofilm or the plaque. And then when you put sealant on these chewing surfaces of the molar teeth, it serves as a physical barrier between the tooth surface and the food debris, and therefore it prevents the tooth decay or the caries. Sealant also prevents the progression of a non-cavitated lesion, and therefore it acts as a secondary strategy as well. So it's really one product giving you multiple benefits of prevention. So dental sealant is also an equity intervention, because when I started my presentation, I provided you a lot of examples and data to show that childhood dental caries is really an equity issue, but dental sealant is really the equity intervention. So we know the problem, but we also know the solution. So the US Community Preventive Task Force has considered dental sealant as a very good strategy, and also very strong evidence of effectiveness has been determined for sealant in reducing tooth decay among school-age children. Benefits of school sealant programs exceed their cost when implemented in schools that have a large number of students at high risk for cavities. Research has also found that implementing a school sealant delivery program led to 26% increase in the number of students who received sealant. So you're really reaching out to those hard to reach children and increasing access to preventive dental services. Greater increases were also seen among students from low-income families, which is definitely how we want to advance equity. Dental sealant or school sealant programs are highly effective for delivering sealants to children who might be less likely to receive regular or private dental care, because now you are helping families to overcome the barriers of transportation, needing to take like flex time from work, the language barrier, because you are bringing sealant into the schools. For approximately 6.5 million low-income children who do not have sealants, receiving sealants in a school program could prevent more than 3 million cavities over 4 years and save up to 300 million in future dental treatment costs. So therefore, dental sealant or school sealant program is not just a cost-effective strategy, it is also evidence-based, and it really advances oral health equity. And that is the reason why Healthy People 2030 goal is to increase the prevalence of sealant, because it's underutilized. Right now we have, so the baseline is 37% of children and adolescents aged 3 to 19 years had received dental sealants on one or more of their primary and permanent molar in 2013 through 2016. So the target is to see an increase in this percentage, and the target percentage is 42.5. So it looks like even though we know the solution and it is evidence-based, schools dental sealant program or dental sealant is underutilized. If you look at the trends in sealant nationally, we are doing better in terms of reducing the caries among children, and Mexican American and children from low-income families have seen the greatest declines in untreated tooth decay. If you look at the sealant prevalence, it has increased by 35% among children, and sealant prevalence among Mexican American and children from lower income nearly doubled. So even though we are seeing good progress, we are not there yet that all the children who are eligible to get the sealant have received it. So there are still opportunities for us to do more. In Minnesota, we found that 6 out of 10 Minnesota's third graders did have sealant. But again, when we do these open mouth assessments, sometimes sealant may not be fully retained. So those biases are there, but at least we know that we are doing better than our national average, because 6 out of every 10 Minnesota third graders at least had evidence that they did get sealant at some point. Do we have any questions so far about the inequities, or just any questions around sealant? Or Dr. Phipps, you want to add anything to what I just mentioned before I get into the evidence-based guidance for sealant use?
So this is Kathy. I don't have anything to add to that.
Okay, thank you, Dr. Phipps. Nancy, do you see anything in the chat? Or are there any questions? Okay, so we get to move on. So the next section is really talking about a lot of frequently asked questions in sealant. And what we're going to do is provide you the evidence-based information about those frequently asked questions, so that you're able to decide what you want to do with your local school-based sealant program. So one of the most common questions we get about school-based sealant program is, what is the effectiveness of sealants in preventing caries initiation? So available evidence suggests that sealants are effective and safe to prevent or arrest the progression of non-cavitated carious lesion. This term might be a little bit too scientific for our grant managers, so I just want to take a moment to explain non-cavitated carious lesion. So carious lesion means, there is an evidence that tooth decay is present. Non-cavitated means there isn't like a break in the enamel, or there isn't like an obvious hole in the tooth. So, so sealant is effective, and it is safe to prevent or arrest the progression of non-cavitated carious lesion compared with controls without sealants or fluoride varnishes. So sealants are obviously effective. However, we do not know if one of the sealant material is superior to the other, and I'll talk about sealant materials in a bit. The other question that comes up in school-based sealant program space is, what is the effectiveness of sealants in preventing caries progression? So, so there are barriers, and one of the key barriers to providing sealants is concern about sealing over caries. And sometimes it's kind of hard to decide because there are no radiographs in a school setting. So a 2008 systematic review found that sealing non-cavitated caries in permanent teeth is effective in reducing caries progression. So not only that sealant prevents caries, but it also reduces caries progression. That's why sealant, as I mentioned earlier, is both primary and secondary level of prevention strategy. The other question that comes up is, what is the effectiveness of sealants in reducing bacteria levels in caries lesions? So a systematic review found that sealants are effective in lowering those bacteria levels in the lesion. And the practical implication of this finding is that dental providers should not be reluctant to provide sealant because of the concerns about inadvertently sealing over caries. Because, sometimes we are very scared about sealing over the caries versus referring them. But because there is evidence to show that sealant is also effective in lowering bacteria level in a real world scenario where we know our children really have access issue and it takes time for them to get into the dental office, we can seal over caries as well. So there are recommendations from the American Dental Association and American Academy of Pediatric Dentistry. There was like a panel formed to look into the sealant effectiveness and efficiency. So the guideline panel formulated 3 main recommendations, and it's a very important report, or the panel recommendations. So the first recommendation is, sealants are effective in preventing and arresting pits and fissure occlusal carious lesion of primary and permanent molars in children and adolescents compared with non-use of sealants or use of fluoride varnish. So if there is a child who has no sealant, placing sealant would definitely be more effective in preventing caries, right? Sealant is also more effective than fluoride varnish. in preventing caries. The panel also recommended that sealants could minimize the progression of non-cavitated occlusal carious lesion, which is also referred to the initial lesion that receive a sealant. So it prevents cavities or the tooth decay, but it also minimizes the progression. Finally, based on the available limited evidence, the panel was unable to provide specific recommendation on the relative merits of one type of sealant materials over the others. So as grant managers and providers, you might know that in the past, there was a big recommendation or big emphasis on using resin-based sealant, but especially with COVID, we started using GIC, and I'll talk more about that in a bit. So there is no evidence, or the evidence we have is very limited to determine the superiority of one material over the other, is what the recommendation was from the panel. Sometimes there are also questions about four-handed technique, and does that really improve sealant retention? So using four-handed delivery to place resin-based sealants may increase retention. And maybe at this time, I could ask you to tell us if you are deploying a dental hygienist as well as a dental assistant to the school. Is there anyone who could comment on using four-handed delivery for sealant? It might be interesting for us to share that and how it works. Maybe Claire or Holly, do you guys want to chime in?
Yeah, I will. I was just starting to answer that in the chat. Ideally, I mean, four-handed is definitely ideal. And if we have somebody that's available when we're in a school and they are able to help, like if they're in between patients, then four-handed is definitely ideal because of the isolation. A lot of these kids, they have very active tongues and their tongues go everywhere. And then they have a lot of saliva. And so, we want to make sure that we're putting the sealants on that they're going to stay on. But in a school setting, in reality, sometimes that's just not possible. So we have to do two-handed. But how I kind of get around with that is I let the kids be in charge of their section, and they love it. I mean, I give them the suction and they are moving it around and they're holding it. And then I have in their other hand, they get to hold my curing light. And then I'm like, okay, when it's time. I mean, so I'm actually really involving the patient when I'm doing sealants. They get to hand me stuff. They get to be in charge of their section. They get to, yeah, so that's how I do it, and the rest of my team, that's how we do it.
Yes, thank you. And there's a big difference between what really works, but what is feasible in a real world setting. So I really appreciate you sharing your experience. Anybody else would like to chime in or add anything else there? Okay. Thank you, Holly.
You're welcome.
So the other question that
hi. Prasida, one thing I was, if I may just jump in, one of the things that I wished I had more clinical time before I stepped out of full-time work, was to explore the use of the suction devices that you see in every one of our journals. That one is supposedly more efficient than the other, but I think that is really something that could be looked at by MDH as well and by the programs, because four-handed dentistry, as Holly said, is the ideal, absolute, to have two people at the chair. It's not always feasible. So that's why the devices have been developed. So I haven't done any research on that, and
Yeah,
some of you are maybe using them.
Yeah, Claire. So when I see these being advertised, I always purchase right away so that we can try it and see how the hygienists like it and how I like it and how they work. Because anything that can help us make our job easier by putting sealants on, I mean, I'm all for that. So there's one device that I thought was going to be like, oh my gosh, this is going to be it. This is fantastic. And it was like a suction. It attaches right onto the suction, and it's supposed to be like a tongue retractor. So it goes between the tongue and the teeth, and then it's the suction that's a part of that. And I was like super excited to get it. But then Julie, who's also one of our collaborative hygienists, she started using it and it just doesn't stay in place. I mean, the tongue is like moving it all over the place. And so then she felt like she had to like use her other hand to keep that in place while she's trying to do one hand. And then she's like telling the kid to hold it in place. And then it became more of a chore than not using it. So that was kind of disappointing. We've used like those pink petals and kind of the same thing. We have not, with purchasing all of these different products, I have not found one that is like, oh my goodness, this makes our life so much more amazing. So if anybody else has tried any and that they've been really successful, please let me know so that I can go ahead and get it for our team and we can give it a try.
And again, another communities of practice topic. Perfect
Yes.
discussion forum for that is who's tried what and who's, so for the future, that would be a to-do list thing.
Yep, and that's a very good topic. I did look at a lot of literature, especially when I was trying to work with the HTDD Best Practices Committee to author the best practices report for a school-based sealant program. But I don't think we talked about isolation and like how difficult it is to keep the field dry, and that helps with the retention. So that is something that we can definitely look into and also bring it up at our community of practice. So thank you, Claire and Holly, for chiming in. So we'll move on. The next question is about does surface cleaning by toothbrush or dental handpiece prophylaxis result in similar retention rates? So there was limited evidence to determine the effect, but there is at least a study that found out that levels of sealant retention after surface cleaning with toothbrush prophylaxis were at least as high as those associated with handpiece prophylaxis. And this finding may translate into lower resource costs for sealant placement. So ever since, Claire, you were doing the calibration training to the time I am doing it, I feel like the evidence has not really changed much. And it's really common for us to use a toothbrush prophylaxis over a handpiece. So I think it's pretty much routine for us to use the toothbrush. And I feel like that's the recommendation that we have from the literature as well. Also, the next question was about the mechanical preparation with a burr, if it improves sealant retention, which is fissurotomy. I did not see a lot of evidence, and when I checked ASTDD's guidelines, it looked like the systematic review and clinical studies could not determine the effect, so it's not really routine in school sealant programs either. Bonding agent and retention is another community of practice question, but so far the recommendation we have from the American Dental Association is that they're leaving it pretty much up to the clinical judgment of a provider to see if they feel like, okay, the bonding agent is really going to enhance retention in the clinical situation. In that case, ADA has recommended the use of compatible one-bottle bonding agent, which contains both an adhesive and a primer. But they are leaving it up to the judgment of the clinicians in this case. The next question is, are teeth that lose sealants at higher risk of tooth decay than teeth that were never sealed? A meta-analysis indicates that caries risk is similar. So if a child has sealant, the sealant is not retained, then the child, it's almost like he never got a sealant. So the risk is similar. Which caries assessment method should be used in school programs to differentiate pit and fissure surfaces that are sound or non-cavitated from those that are cavitated? So for school-based sealant programs, visual examination is appropriate, and educate for caries assessment before placing sealants. The clinician should not use an explorer, especially under force. I have read literature where they recommend using a blunt probe, but visual examination is appropriate and adequate, so no need to use an explorer. Radiographs are not indicated solely for the placement of sealants, and the use of magnification and caries detection devices is also not necessary to determine cavitation. And again, I think I go back to Dr. Phipps' other lectures where she's talking about this is public health surveillance. This is not precision, So we're looking at, not just cost-effective intervention, but we are also looking at what is more efficient thing for us to do when we are in a setting where there are no resources. And as Holly mentioned, sometimes it's only the hygienist actually doing the work. So the simple, the better. So again,
Prasida, I'd like to add one comment to your last slide. Visual
yes.
examination is appropriate, but I think what we also need to do is visual examination under adequate light, because you need to have a combination of an appropriate light source plus the visual examination. And research has shown over and over again that visual examination with a good light is probably the best way to detect caries.
Great.
Mm-hmm. And Dr. Phipps, I have a question for you. I know we were using a certain light for our basic screening survey. Do you have any recommendation for what that light could look like for our school-based sealant program?
For the school-based sealant programs can use the light that if they're using loops, you can use the light from the loops. It's probably better than a flashlight. You don't have to hold it, for one thing. Or a portable exam light would be the two that I would recommend.
Okay, because our sealant grantees can also use the funds to buy these lights. So if you have any recommendation for like specific.
I don't have a recommendation for a specific brand of light.
Can I hop in? I'm sorry to like kind of keep jumping in. What we use for Let's Smile is they're fantastic. They're the headlights that you can buy like at Menards and Fleet Farm and stuff like that. They're basically just like the headlights that you could put on around your head, and then they have like 3 different light settings. It's like kind of a low light, medium light, high light. And holy cow, do those really like light up the surface, and you can see everything with those. They're very reasonable because you can buy them at like Fleet Farm for probably about anywhere between $5 to $10, and then you just put in batteries as needed when the batteries wear out.
And I know they also make wands now. My husband has one that he uses for camping. It's the 3 lights, and it's actually rechargeable.
Oh.
Yeah, that sounds like what we use. I mean, we don't have the rechargeable, but we definitely we go through a lot of batteries. So that's what our sealant funding goes towards.
I think we are using that for our BSS. It's really easy because it's like a headlight, so you don't have to like keep holding it, sort of. So we'll look into the visual, more like the lights that we can use during our community of practice as well. Thank you. So the next bigger question is about sealant materials, and is one material better than the other? And especially after COVID-19, there has been a lot of conversations about using the glass ionomer cement, the GIC. For me, because I was trained in Nepal, GIC was my constant companion. We use GIC a lot. So for me, GIC is not something new, but it's really a very good, cost-effective, and very easy to use material. But here, I think it's being talked about more now after COVID because of aerosols and many other advantages of GIC, and I'll talk about that in a bit. So at one point, I think 2008, ADA recommended resin-based sealants as first choice, and which was based on 2004 Cochrane review. But the ADA panel was unable to determine the superiority of one type of sealant over the other, owing to the very low quality of evidence, which was the 2013 Cochrane review. So at this time, staying with the ADA panel's recommendation, there is no, not one material is not better than the other. However, there are certain indications to use the materials. So for example, Clinicians could consider retention when choosing the most appropriate type of sealant material. And we did talk a lot about, isolation and how difficult it is. So GIC could be is a better option when you're struggling to keep the field dry. And also for erupting molars, GIC might be a better option. So do we have any other questions regarding sealant before I get into the implementation part of it? Are there any other questions that you have around sealant or the evidence? And Dr. Phipps and I could help answer those questions. Dr. Phipps,
One of
anything
the
from your side?
one of the questions that has arisen in programs that are using the GI sealants is being able to actually identify whether or not the sealant is being retained. And ASTDD is looking into, using a black light potentially to be able to improve visualization of it to see whether or not they're actually being retained, because sometimes it can be difficult to see them.
Yes, Dr. Phipps, and that's a very good point, because we used the black light for our BSS, because sometimes the sealants are so well done that you can't differentiate the resin-based sealant. So I feel like it's a very nice tool that we have as an option. And it's good to know that ASTDD is looking into it as well. Anything else, Dr. Phipps, from your side? And did we miss out any important questions other than that?
No, nothing else.
Okay.
Except that I will say that many of you may have had outside providers question the usage of dental sealants. Now, I will say that all schools teach that dental sealants are appropriate, but what you will find is that there are outside dental CE providers that will encourage dentists as a way to increase revenue to do enamel removal prior to placing the sealant. So placing a PRR rather than the sealant itself. So a lot of that's coming out of continuing education courses. And there are a couple of CE providers that really push doing PRRs instead of sealants. I will say that there's just no evidence to support that traditional sealants are just as effective, and you do not need to remove tooth surface for it.
Mm-hmm. That's good to know, Dr. Phipps, about the continuing education and the revenue generation part of it as well, right? Thank you, Dr. Phipps. So maybe we'll move on to the implementation part. So what I'm trying to do with the implementation part is to focus a little bit on the grant aspect of it, or just the programmatic side of it. But there are a lot of overlaps with just the evidence that we just talked about. So when we talk about the implementation of a school-based sealant program, there's a lot of autonomy provided to the local program, and they can operate the way they want. So as MDH or-led program, we would just provide, our role is to provide you the best practices and evidence-based information. But as brand managers and as independent entities, you would decide what works best for your program. So local school-based sealant programs have a lot of flexibility in terms of what materials you would use, choose to include additional information on program forms, or how you decide to foster return of consent forms. It's really up to your organization. There are regulatory compliance at the state level where, at least in Minnesota, we know our collaborative practice dental hygienists are able to provide the sealant without the dentist being on site, which is a huge, which is a very good workforce model that we have in Minnesota. We are also required to follow the Occupational Safety and Health Administration guidelines to make sure that we prevent injuries and also protect the health of professionals. So these are local program operations that we need to follow. So there are a lot of questions we were getting around, just to how to get started with the school program. And we've also been working with non-dental partners, including local public health agencies, who are very interested, or like community health centers who are very excited to start the school Sealant program, but they don't even know where to start. And we do have dental hygienists who are, who just have become like collaborative practice dental hygienists, so they don't know where to start. So just to make sure that everybody's on the same page, I wanted to start with the basics of where do you actually get started. So when we are looking at the school selection, we are trying to target schools that have been categorized as high-risk schools based on the free and reduced price lunch eligibility. So that means if there is a school where 50% or more children are eligible for school lunch program, then that's the school we should be prioritizing. MDH oral health program would be more than happy to help you select those schools so that you are still within using the 50% or more free and reduced price lunch eligible schools. There is also another index called Social Vulnerability Index, which also helps you determine a county or schools based on not just the free and reduced price lunch. It also helps you look at the housing, employment, and a lot of like socioeconomic aspect of that particular county. We have not really used it as of now, but that could be a good measure for us to use in the future as we look at these communities and the schools. So as you can see on the slide, there are over 200 elementary schools in Minnesota that do not have a school Sealant program. And we don't even know how credible our data is because we were collecting the data based on our networks or other sources, but there's no mechanism for us to even have a database of that baseline. So as you can see on the slide, there is a map that shows high-risk schools with these stars and flags, and it also shows the distribution of school Sealant program. So you might also wonder about school-based health centers. There are 27 school-based health centers in Minnesota. And what we found was only 7 of them offered some dental services, but rest of them were just referring the children to dental providers, and there's no like warm handoff or loop closure. The other big equity issue with school-based health centers in Minnesota is that 27 of the health centers are all based in urban regions. There isn't anything that's in more like rural areas, which is really like a big issue. The third issue that we found out with school-based health Sealant as we were trying to expand our reach was most of them are co-located with middle and high school. And for school Sealant program, we want to really target kids when they are in their second grade. So there are fundamental issues, more like structural issues when we are trying to select schools or trying to see if school-based health center is a right entry point for us to get into these schools. But we are so thankful to our Seal Minnesota partners. They have screened 6,107 children in 147 Minnesota public schools. This is based on our data prior to COVID. We just finished the first round of grants after COVID-19, so we still have to analyze the data. But Seal Minnesota grantees increased the school sort by 27%, which is huge. And around 10,241 children attended chairside or group education, and almost 96% of them received fluoride varnish, and almost 40% of children received a dental sealant. So we are very thankful for the impact that our Seal Minnesota partners and grantees are playing in improving access to sealant or reaching out to these schools. So once you go to the school, because this is more like a dental public health approach, we are not doing risk assessment for individual child. So once you determine a school, that's the smallest unit for you to, to select. So if the school is already selected based on their free and reduced price lunch eligibility, then all children in that school are eligible to receive sealant. And we do not want to single out any specific student to avoid stigmatization. However, there are also groups of children, maybe they are from refugee groups or immigrant groups, or some of them may even be undocumented in the country. So they may not be eligible to, for, to receive the benefit. So we would really hope that our system is a little bit more flexible, or like we build into some flexibility to accommodate those children into our program and somehow make sure that they are not excluded from getting the sealant that they need. And talking about the priority teeth, as I talked about those molars and grooves and those pits and fissure sealant is most likely to occur in the first and second molars. So these are our priority teeth. Many programs target only students in second grade because rates of erupted non-carious teeth tend to be greater than for students in either first grade or higher grades. And follow-up in the third grade is more or less a routine procedure for most of our local programs because of a couple of reasons. One, when we are following up with kids in the third grade to the assessment for sealant retention, repair, or replacement is needed. So it helps us, it really gives us an opportunity to see if the sealant has been retained, or if we need to replace it, that's the right time. And it also helps to seal previously unerupted molars. So that is the reason why sealing the teeth in second grade is more common, and also following up in third grade is what we are seeing. So when you are preparing to, now let's say you have a school, which grade to target, which teeth to, like focus on. And once you are starting to prepare to launch, obviously you would do staff training. This presentation is also more of the staff training, but your agency might be able to train your staff in some of your organizational, practices. Scheduling schools to come in is a big part of it, and there are different recommendations for scheduling. It is also recommended that we coordinate with school nurses to see if there are any other health screenings or events going on, so we can go in at the same time, which makes us align with other health initiatives going on in the school. And also obtaining parental consent would be an important consideration as we prepare to launch the school sealant program. Program setup includes a lot of things, from inspecting the area to equipment setup, how you do your sterilization, getting the parental consent form signed. And I know many of our grantees are being innovative by providing incentive to teachers or using different electronic system to reach out to parents. And also making sure that the health histories are obtained just to make sure that we are not missing out on anything. It would require a lot of collaboration with school nurses. Program setup would also include us thinking about portable dental chair or a lot of supplies related to treatment, sterilization, those personal protective equipment, and additional supplies that you may need to provide to the children. Maybe these are educational books or toothbrushes. I think those are all part of the program setup. So Holly did talk about how even though, 400 dentistry is ideal, it may not be possible for us to have two operators at one time, but there are specific guidelines that we have received from Seal America Toolkit. And I brought in a picture to show everyone how the screening could be, how the assessment could be facilitated. So it really looks like the assistant would go into the classroom, pull the kids out of the classroom, bring them to the assessment area, and then the dental hygienist is doing the assessment and also placing the sealant. Some of you might be doing the assessment at one time and going back for sealant at a different time. That could be another option, but some of the things that we could record during student assessment is really the assessment date, caries history, presence and location of untreated caries, your code and signature, presence and location of existing dental sealants, location where sealants need to be placed, and any notes concerning the student's behavior or a specific recommendation for that student. So now coming to the specific guidelines for tooth surface assessment and dental sealant placement. So the most important thing when you are determining the surface of the tooth for sealant placement or eligibility for sealant placement is to differentiate between cavitated and non-cavitated lesion. We're going to use the visual assessment, and as Dr. Phipps said, maybe we add an adequate lighting, so we really make sure our visual assessment is enhanced. And then dry teeth before assessment with cotton rolls, gauze, or when available, compressed air. Then an explorer may be used to gently confirm cavitation. Do not use a sharp explorer under force because that causes trauma to the teeth. Then x-rays are unnecessary for sealant placement only. Other diagnostic technologies are not required. So basically using our visual assessment with adequate lighting to see if there is any cavitation on the teeth will help us determine the eligibility of the tooth. And once you know, once you are able to assess the tooth surface, the indication for sealants are also summarized on this table. So if you see that the tooth is caries-free, you would go ahead and seal the tooth. If you see that the tooth has non-cavitated caries lesion, you will still go ahead and seal the tooth. If the teeth with cavitated lesions with no visual signs of dental caries, you will not seal the teeth. So the idea is you would only seal a sound tooth or tooth that has non-cavitated caries lesion, but you would never seal a tooth with cavitated lesions. And if you see that there are teeth or individual tooth with cavitated lesion, you would not seal, you'll refer for treatment. Dr. Phipps, do you have any other comments here for tooth surface assessment or dental sealant placement that I might have missed?
No, I don't.
Okay. So I found these tables very handy, so we can provide you a copy of these tables so you can have it, in your folder for school. Also, sealing buccal and lingual is very important clinical consideration because buccal and lingual pits are the two most frequent surfaces of sealant failures, and sometimes we tend to avoid these surfaces, which are shallower and difficult to reach. So, however, a national survey found that buccal and lingual surfaces are the second most common caries sites for children. So please be sure to seal the buccal and lingual and strive to improve retention. Also, going back to selecting dental sealant materials, now that you're actually doing the program, make sure that the material chosen should appear on ADA's Seal of Acceptance program list, and we can share the link with you. So when you are selecting dental sealant materials, or when the grant manager is looking at which material to pick from programmatic perspective, we could look for certain variables. One, you could look at the cost-effective materials that have prolonged retention properties. Second, you can look at a material that has low solubility in the oral environment, or you could also look at a material that is really simple to apply. But always remember that there is no one material that is superior to the other, and also the type of sealants, bonding agents, and enamel agents should also be considered carefully. There are 4 different types of dental materials that are commonly used in school-based sealant program. Many of you are already familiar with the resin-based dental sealants. The next one is the glass ionomer dental sealant. We also have polyacid modified resin dental sealants, and we also have resin modified glass ionomer cements. So there are lots of factors to consider, again, when you are selecting which material to choose. All materials are effective, so there is no sealant material that is more effective than the others, as I've been mentioning. However, the effectiveness of resin-based dental sealant is very technique sensitive, and we did hear about the difficulty of isolation and keeping the field dry. So to adhere to the tooth, resin requires an isolated, absolutely clean, dry enamel surface, which is sometimes difficult to acquire if the teeth are partially erupted or if the student is uncooperative. So in those cases, GIC can be used, especially if you are sealing a partially erupted occlusal surface. And over the time, the GIC have lower retention rates than resin-based dental sealants. However, there are some studies that have looked into the effectiveness of GIC even after they are not retained. There could be some microscopic tags of sealant bonded to the tooth that allow a sealing effect deep in pits and fissures. So because there are those studies that are emerging, GIC has very good advantages over resin-based, especially if you are working with partially erupted occlusal surfaces and the child is uncooperative, or it's very difficult for you to maintain a dry field. BPA consideration is there. I know some of you have expressed concerns about BPA. I do hear it nationally as well. So, I really like this infographic that clearly states that breathing air exposes people to about 100 times more BPA than dental sealants. So there is really no concern about BPA that is in the sealant, and it is the component of some of the dental sealants, but it's really, the effect is really negligible. So there is nothing to worry about BPA in sealants. So the overall guidance for school-based sealant program is that we could seal sound surfaces and non-cavitated lesions. We will use visual assessment to detect surface cavitation. We will also use a toothbrush or a hand-piece prophylaxis to clean the tooth surfaces. Again, toothbrush is really more common practice, and provide sealants to children even if follow-up cannot be ensured, because so many programs have concerns around follow-up, and obviously I would like to make sure that the child gets at least the oral urgent treatment, but in a dental public health setting, at least placing sealant is already a big step. We will try our best to refer the child and do a warm handoff, but it may not be always possible. So instead of worrying about that part and feeling guilty about not being able to do so, I think it's still important for us to place the sealant, because you're already doing a lot by helping a child prevent or arrest the caries. Are there any questions about the implementation before we move into the clinical pictures and infection control? Or Dr. Phipps, anything from your side you wanted to add?
No, I don't have anything from my side, but I will need to be signing off in about 10 minutes.
Okay, so we'll be almost done with the part. Are there any other questions from the audience? Okay. So now we will move on to the clinical exam. And we have clinical photos of permanent molars at different stages of lesion development, from sound to cavitated lesions. Each photo includes in the title the status, whether it's sound, non-cavitated, and cavitated, and the treatment indicated. Also, photo include a clinical description of the lesion. So when you are looking at these pictures, please remember that your screening relies on visual assessment only, and you could use a good light, and think that you are not using an explorer or radiographs. And then towards the end, I will also do a quick assessment to see how much you were able to get from this presentation. So for now, we are just going to review some of the pictures. So the first couple of pictures are sound surfaces. So two molars that show no changes in color in the enamel spits and fissures. So because this is a sound, these are sound molars, we will go ahead and seal these teeth. Next, we have, again, sound surfaces. As you can see on the picture, the teeth looks pretty good. So we're just going to go ahead and seal the teeth. So there could be some situations where you encounter non-cavitated lesions. So non-cavitated caries lesions refers to those pits and fissures in fully erupted teeth that may display some discoloration, not due to staining, not due to extrinsic staining, but really developmental opacities or fluorosis. So it's not because of staining or fluorosis. The discoloration may be confined to the size of the pits here, or fissures may extend to the cusp, inclines surrounding to a pit and fissure. So the tooth surface should have no evidence of shadow indicating dentinal caries. And again, this is just the visual examination. So, and if radiographs are available, they should be evaluated to determine that neither the occlusal nor proximal surfaces have signs of dentinal caries. So non-cavitated lesions here, you would go ahead and seal. Again, the pits of the occlusal surfaces show change in color. I don't know if you're able to see that on the slide. The pits of the occlusal surfaces show change in color following the anatomy of the fissure. But because there is no cavitation or obvious break in the enamel, we are going to go ahead and seal the teeth. These two extracted molars show the same type of non-cavitated lesions in the central fossa here. So because these are non-cavitated lesions, we can go ahead and seal the teeth. Sometimes non-cavitated lesions show a decalcified areas around the pit and fissures, which are visible after drying. So if you are seeing those decalcified areas, but you do not see an obvious cavitation, you can still seal the teeth. So decalcified areas around the pits and fissures, which are visible after drying, because these are still non-cavitated lesions, we would go ahead and seal the teeth or the tooth. So the molar on the left has non-cavitated lesions all over its pits and fissures, and the molar on the right has non-cavitated lesions restricted to the central and distal fossa here, but because they are non-cavitated lesions, we can still go ahead and seal the teeth. When you see obvious cavitated lesions, we will not seal the tooth, and then we refer for treatment. For example, these two molars have cavitated lesions extending beyond the usual limits of the pit or fissures. These lesions usually have underlying dentinal lesions, which may be visible at examination. So because you see the cavitated lesions with your visual examination, we cannot seal the teeth. Again, cavitated lesions here. These two molars have cavitated lesions extending beyond the usual limits of pits or fissures. So that's why we don't seal the teeth and we refer for treatment. This is, they can obviously cross-indicate tooth. So there is a big cavity here. So we don't seal the tooth and we refer for treatment. So I think, Claire, maybe you could comment on this picture because I borrowed this picture from your previous slides. Sometimes you see the tissue covering the erupting molars or opericulum. So what do we do with this kind of situation? Claire, do you want to comment here? Because I borrowed this picture from your slide. So what do you do with those erupting molars where you see tooth still covered with some tissues? Or anyone can chime in, including Dr. Phipps.
Well, yes, if Claire is not available to respond, this is a good opportunity for a GI sealant that you can actually, because you're not going to be able to get that area dry, that's when a GI would be appropriate.
Yeah. So this is a very classic case where GIC is indicated. And I think this is, instead of trying to wait for the tooth to fully erupt, it's better to use GI and seal the tooth as much as possible. So that's why I brought in this picture, just to emphasize the role of GI. And sometimes you see a fistula. So in this case, it's definitely a referral. And then I did bring in some tables to show the guidelines to place to apply dental sealant, both for resin-based and GIC. And as Minnesota Orlet program, we were trying to come up with our own video tutorials or considering, whether we should do this in person. And we've been working very closely with Oregon Department of Health, and they've allowed us to use their materials. And Oregon has one of the best sealant certification programs. So I've been working very closely with Karen, and she had allowed us to use the material. So instead of trying to reinvent the wheel, I'm going to share the videos, video link from Oregon's website. And they have also added video for GI placement, which is really, really good video. So instead of trying to go over all those placement technique now, I can share the video link with you and you can watch them at your own pace. One big thing about school-based sealant program is retention, right? And retention is always a process outcome. So research has shown that a retained sealant can be 100% effective. And the reason why we talk about retention, I feel like personally, I'm just obsessed with retention because think of it in this way. I describe that sealant acts as a physical barrier. It's both like primary and secondary level of prevention, and it's really a physical barrier because it keeps the food and other debris out of the tooth surface, and that's how it prevents caries. So imagine like the half of the sealant is gone, or like there's no retention of the sealant. That means there's no point of placing sealant, right? So as long as retention is ensured, we know that sealant is going to be effective. So we already know from research that sealant is effective, provided that it is placed correctly. So that's a big thing in school-based sealant program where we are trying to, like do all this work, but we don't have enough resources to go back and check for those retention. And that's the barrier for many of our programs. But for state or led program, we have to make sure that we are also improving the quality of the school-based sealant program. So I just wanted to share it with you that retention is a process outcome, and it really demonstrates how well your program is operating, because if we are placing sealant correctly, it will retain, right? So we are not trying to verify the effectiveness of sealant. We know it works already, but it's very technique sensitive. So we want to make sure that sealant is retained. Also, reduction in caries is the true health outcome. So if you are looking at the outcome for your program over the years, like how well we are doing in reducing the prevalence of the caries is where we are, moving towards. Preliminary research indicates that although glass ionomer has less retention visually, a residual amount of materials might remain back. The tags I was talking about, releasing fluoride for an undetermined time, and has the potential for being recharged with topical fluoride as well. So the inference of this slide is please continue to monitor and report retention for quality improvement purposes. And for quality assurance, retention check is really, really important. And it can detect clinical problems related to application technique, equipment, and dental materials. So as grant managers, making sure that your program is doing retention check is very key for you to determine the quality of your program. There are short-term retention check, there are long-term retention check. In short-term retention check, those are really within 2 months and very situational. Long-term retention check, you're looking at 1 year, and it's pretty routine, right? So you place sealant in grade 2, then you go back in grade 3 and then check for those retention. For short-term retention, complete retention of all sealants is expected. And for long-term, 90% or more of the sealants must be retained. But this time when I was writing the ASTD best practices report, sometimes it's very hard to have these high standards where we want everybody to have their sealants retained 90%. So the best practice committee decided that we should ask the local programs to look at their baseline. What was their retention check baseline? And we want them to improve from their individual baseline. So it's not like a national metrics that we can provide that everybody should have 90% or more, but it's really like how better are you doing from last year? So if your last year, your retention rate was 50%, if you move up to 65 or 70, that's already a good progress for you. So that's how I think the retention check have been tailored to meet the resources and also to meet your local needs. For short-term retention, you're using visual and tactile techniques. And also for long-term, you're using the same techniques. For short-term, 10 to 15 students per school are pretty much, I think, what's recommended. For long-term, you would check as many third graders who receive the sealants. And short-term retention check could be a useful practice when you have a new dental hygienist who's new to the program, or you are trying to change your clinical protocols, or also using new techniques and materials. And for long-term retention check, it's really to see the quality of your program and finding those various ways to improve the quality of the work. So repair or replacement, the key message from this slide is that presence of caries and not retention is the criterion for sealant replacement. And there are other factors that you can think about, but at the end of the day, it's really, if you see caries, then that's when you replace the sealant. For infection control, I will be sharing some additional links from CDC and some other reports that I've found. But for infection control, one, we have to use the standard precaution and then make sure that we are using fully covered gown, mask, and then also using goggles or face shield, and also using gloves for the school-based sealant program. And there are also infection control practices for school-based sealant programs, very specific tables. I can share the link with you. And I really like the way they've divided different best practices into 4 broad categories. One is to take action to stay healthy, which includes immunization. Second is avoid contact with blood, so using those personal protective equipment. Third is making patient care items safe for use, which includes instruments, disposal, sterilization, and a lot of those things. And fourth is limiting the spread of blood and other infectious body substances, which includes waste handling, surface cleaning, and also high volume evacuation. And there is a whole manual that talks about these 4 domains in detail. So at the end, now we know how to select the skull, the teeth, and everything. At the end, after you place the sealant, obviously in real world, you would see a lot of needs for dental referral. So in Minnesota, what we have envisioned for a dental home model is, we don't see a traditional brick and mortar clinic as only the dental home. It's really everybody coming together to support a child's well-being, right? So it could be really dental hygienists working with community health centers, also working with social workers to help with social determinants of health, public health workers, community health workers, and then there are different school-based initiatives we have at the state level, whether it's school sealant program or community water fluoridation. We all come together to do community clinical linkages, and that's how we think of improving the overall health of a child. And if you look at the ACTD Best Practices Committee's report, there are very clear performance benchmarks, which is kind of the best practices we want the local school-based program to follow in terms of creating an impact and how effective they are in reducing the caries, how efficient they are in terms of trying to use the cost-effective workforce at the top of their license. Also, are they sustainable? Because most of the school sealant programs are funded by grants. What is the sustainability plan if the grant goes away? And are you sustainable by, targeting those high-risk schools? Also, are you fostering professional collaboration and integration? Have you been trying to work with school nurse? Are you able to schedule your sealant days with a hearing or visual screening days at the school? And also how close you are with, the community centers for community clinical linkages. And also that even though we have Healthy People 2030 goals, do you have your own set of metrics or data? And how often are you not just like collecting the data, but disseminating that data for planning and other policy purposes is what the objectives or rational is all about. So you can really look at that document and read in details about the tips that they have provided in that report. And some of the resources are definitely the ACTD Best Practices Committee's report. It just explains everything that I've discussed today in the presentation. I also love the Seal America, the Prevention Initiative Toolkit. It talks about A to Z of school-based sealant, the ACTD Dental Sealant Resources. I love the Ohio Department of Health School-Based Sealant Program Manual, Oregon's website for sealant certification, CDC website, MDH Oral Health Program website. These are all wonderful resources that we have to help you be successful in your program. Do we have any questions? I know Dr. Phipps, you said you had to step out. I'm not sure if you are still here. I think Dr. Phipps might have left. Are there any questions before I get into the quick assessment part? And I'm not going to check your answers, so don't worry, just for you to see how much you've learned. Are there any questions or comments? Maybe Anne, do you want to comment on anything? Because I know, I just want to make sure that the presentation was helpful to grant managers as well.
Yes, it's very helpful. I appreciate that you invited us to it.
Okay, so I'm going to show some pictures and let's take it as a fun activity. This is not to judge or anything. We've and I'll be very intrigued to see how grant managers do on it, because you know these are very, I'm trying to keep it very simple for those who are not clinical as well. So I'm going to share my screen. And can you confirm if you are able to see my screen?
I can see it.
Okay, so we're going to do a quick quiz. I'm not trying to trick anyone, I promise. Okay, so we ask you to take out a piece of paper and record a response for each number after viewing the clinical images on the slides. And your response choices are yes, seal the tooth, no, do not seal tooth. And then at the end, I'll show you the answers and we'll go over those images again and see if you got stuck somewhere or what questions you might have. Okay, so this is the first clinical picture here, and we are asking you to focus on this particular tooth here. Oops, here. So the question is, would you seal or not seal? So on a piece of paper, you could just write number 1 and then write your answer. Seal or not seal? Okay, we'll move on. If you need more time to look at it, please let me know. Please unmute yourself and let me know. If not, I'll move on to the next slide. So the next slide has 3 teeth that you can see on the picture. The question is, are you going to seal or not seal? So the third slide shows, I think you can see only one tooth here, probably. And I don't know if you are able to see that there is some discoloration here, this area. Okay, that's your tooth number 3. So tooth number 4, we are asking you to focus on this particular area here. So next slide, we have both, like there are a couple of questions here. So we'd like you to focus here, this section, and then there's something going on here. So that's your number 6. So 5 and 6. So we have 4 images here. I know it's a lot. So we'd like you to focus on these areas here. And also for image number 8, this area here. Tooth number 9. And then tooth number 10. Please let me know if you need more time. Okay. This is the 11th picture. And we'd like you to focus on this area here. So would you be sealing this tooth or you would not be sealing this tooth? So tooth number 12, there are a few things going on in this area here. Oops, I'll go back. Here. So what would be your decision for sealing or not sealing the tooth? And then tooth number 13. Just focus more on this area that you can see in the green, green surface here. So that's your tooth number 13. Oops. Okay. Do you want me to go back to any slides so you can take a second look at it, or you're good? Okay. So we look at the answers, and I have the answers here, but I'll show you the pictures again. So for tooth number 1, for some reason I'm not able to see here. Give me 1 second. Okay. So for tooth number 1, the answer is no. We would not seal this tooth because you can see the interproximal decay here. It's visible to our eyes. So then this is a referral case. For tooth number 2, yes, we would obviously seal this tooth because there isn't anything going on. It's a sound tooth surface. For tooth number 3, we would not seal this tooth because there's untreated decay. And I mentioned earlier that there is a little bit of discoloration here that you can see, which indicates a dental, like evidence for dental null caries. So this is a referral case. So for tooth number 4, there is no cavitated lesions here. This looks like a decalcified area, even though it looks like this is a little bit of, this is cavitated. So then we would not seal the tooth because there is a cavity here. It's a break in enamel. But this part, if you were looking only at this part, then this is more like the calcified area. But because there is a cavitated lesion here, you would not seal the tooth. So for the 5th image here, you would seal the tooth because it's non-cavitated lesion here. And for tooth number 6, you would seal because it's non-cavitated lesion here. So both are non-cavitated lesion, so that's why you would seal the teeth or the tooth here. So there were multiple images here for tooth number 7 with the visualize. When I looked at the picture for the first time, I'm like, is this like a a cavitation here? But it's actually it's non-cavitated lesion here. And it's more like a stain. So then you would seal the cavity. Sorry, you will seal the tooth. So for image number 8, you would seal the tooth because it's a sound tooth. 9 also is a sound tooth. It's very obvious that it's a sound tooth. So you would seal the tooth. And number 10, you would not seal the tooth because there are cavitated lesions, and it's very obvious here with the visual examination. So for tooth number 11, you would not seal the tooth because there is an obvious untreated decay here. A big cavitation is here. And for tooth number 12, you would seal the tooth because it's more like dry tooth surface. It's etched, so it's not like a cavitation. So for tooth number 13, you would still go ahead and seal the tooth because it's non-cavitated lesion, and then there is like a little bit of stain. So I don't know who got the highest out of all those images. I could offer them some gift hampers if they're willing to share. If somebody got 100%. Okay. And was this interesting to you, and to try to seal or not seal?
This was really interesting. And I got 3 wrong because I'm not a dental professional, but when, I didn't really know sometimes if it was a big stain, if it was a cavity or not.
But you still got so many correct, right? Being non-dental
Well,
providers. That's amazing. Anybody else would like to share anything about their results or overall training? And I think that's the reason why we need the standardization training, because as clinicians, we view cavitation and a lot of things in different ways. So this kind of training would help us all be on the same page. I think that's the idea. And it's very nice to have brand managers and, like providers doing this exercise together, because it's important for us to be on the same page, right? Any comments, Claire, from your side, or anybody else would like to chime in just about the presentation?
I still was stumped on number 6, and since I think these slides we worked on together, maybe Prasida years ago, so I should have gotten 100% on it. But
I added new slides also.
I know you're sneaky. One of the things, you may have mentioned this, but the dilemma we run into when we do this calibration training and these sorts of exercises is really important to do it frequently, because we have to remember, was it Amber that maybe mentioned, somebody mentioned that that there's no, or maybe it was Anne, that there is no dentist to send this child to. So it's a real ethical dilemma and a professional dilemma when we're looking at that tooth and saying, I know this is early cavitation, but I know that that child has no place to go, and the parents are undocumented, or anything of that nature. So that's where the professional judgment, critical thinking, that we hear about critical thinking all the time. So this is really important stuff to do this.
And Claire, do you remember, like, there used to be a big controversy around sealing over caries and not referring, and the scope of practice, but that there's clear evidence that from systematic review that shows how sealant also decreases the bacterial level in the lesion. So I don't think that we need to be worried about inadvertently sealing over the caries. I think we are just buying the time. I feel like there is also silver diamond fluoride and other treatment modalities that are coming up that could help, but sealant is very safe and effective, and we know the kind of population we are working with. So just being mindful that it's a very high risk population, and you may be the only provider who might be providing this care.
Right.
So you're using there's more good than harm in this case. And that's ethical, right, for us to do anything that benefits the patient. So I see it that way, at least. Anything else? And I wish we could have done proper calibration training, Claire, like how you did at Normandale Community College. And I was sort of like conflicted whether I should keep it super clinical or also really invite, and you, Ariana, and Crystal, you guys are doing a lot of programmatic stuff, but you also need to know about materials and like these best practices. So I was trying to find a balance between clinicals and programmatic, and still make sure that we all have this equity perspective to look at sealant and how much it's important. So I don't know how this was. Claire, you used to do the calibration training, so big shoes to fill in.
It was very, very, very good. And you can always do it again.
We can always do it again, and hopefully this time we can do it in person, so to do more like calibration. Anything else as feedback for future trainings, or any other comments about just the calibration exercise? I want to give out some hampers. Maybe Crystal, or I see Amber, and then I see Julie, Laura, Holly's there, Missy. Anything else from you before we let you guys go?
I want to know more about these hampers. Tell me about the hampers that you were going to give for gift, and then
I'll tell you. That's a secret. You need to tell me your scores first, then I'll give you the hamper. I'll bring it tomorrow.
Okay, so I got one wrong, and it was the number 7. And I was really on the fence on that one, because it appeared, but I like, oh, I wanted to like put some air on that baby and see what was going on with it. So I did get one wrong. So now tell me about the hampers.
Okay, you'll get it tomorrow. I promise I'll bring it.
Okay.
Okay. And Crystal, are you able to speak? I just wanted to know perspectives from, more like programmatic folks also, so that we know how to balance this in the future.
Sorry, I just realized you said my name. I had stepped away from my desk. Can you repeat the question?
The question is because we tried to combine the clinical as well as the
Oh.
programmatic
Yes.
sort of thing so that we could all come together and talk about it
Yeah.
as a team.
I thought it was great. Yeah, I really enjoyed it as well. And I enjoyed like doing the tests that you provided for providers. And that was fun to kind of see and participate in. I thought all the information was really wonderful and
And you got
current.
many rights. You got
I
many rights.
I did actually. I only got one wrong. And so you're a great teacher,
So,
Prasida.
wow.
Okay. Oh, I feel so good. And Claire, like we've not done with programmatic folks, right? So it's so interesting that they're getting everything right. This is fun. Crystal, you also get a hamper tomorrow then.
Oh, thank you.
Okay. So I think that helps us set the tone for Claire and I to follow up and see how we can take the calibration and these kind of training, maybe in person or make it more interesting in the future. But this was good too. I
Very
think
good.
for years, I was like, I don't think I can do this. Claire used to do it, so it's a big shoes for us to fill in.
Oh,
But there'll be more conversation going on to see how we can continue these trainings for the future. Thank you, everyone. And then hopefully...
What time is it tomorrow, Prasida? What time for sure tomorrow?
I think, wasn't it 10?
10?
I
Okay.
think 10. I think there would be another email coming out to you guys.
Okay.
I thought it was 10 tomorrow.
Thank you.
Okay. Thank you. I'll see you tomorrow.
All right.
Bye.
Thank you.
Bye.
Bye.